see. Okay, cool. Cool. Now I see some of you. Excellent. So let's start as usual. So I hope you are familiar with this forum where we have the images and everything. But anyway, I'm gonna share. So I need to go to chat, and then I will share the link to the images. So you can open the images and take a look. Otherwise, as usual, I'm gonna share my screen. Which screen I need to share? It's gonna be one. Yeah, perfect. Share, and then okay. So today's, I hope, I don't know. It's in my eyes like a beautiful case, and it's not a case where I think you should face saying I need to know it. We're gonna try to unfold it or go through the case together. I think at the end, we're gonna look at it back and you will see that it's a beautiful case. There are many, many things to learn from it. So history is here. So it's a young dog. It's a classic vomiting young dog. And then the question mark is, do you need to do surgery or not? Is this obstructive or not? Is this enteritis or a foreign body? Okay, so that's basically a young dog. It's a very classic, presentation in history. So that's the background. And then let's go to the case, to the images. Okay, here we go. I'm gonna put this here and then do an adjustment to my screen. So you use only one. Beautiful. So there are a number of images. Let's decide which ones we're going to pay more attention, and then we can go through all of them. There seems to be no label in this one. So if we use the Colvina cava and the diaphragm, this is on the stomach. This is likely a right lateral projection. This one is very hard to know because we don't have the diaphragm on. There's a left here. Okay, so right, left, that's good. And now we have this one. Oh, let's bring it here. And then let's bring this one here. So this DB is not that good. Probably this one is better. So technically is not 100 points. It's like a real life case. I think these were taken overnight, I think. And this is what we have. So classic presentation, young dog. Is it enteritis? Why is this dog vomiting? Is it surgical or not? That's kind of the big question. So we'll do as usual. So we bring everything out, all the observations, all the descriptions, everything. I take notes, and then we see if we all agree on the findings. If we don't agree, we go through them again, and then we try to conclude something out of those findings. And this case is cool because I have the answer. So it's not a case where we're going to end up saying, well, we don't know, it could be this, this, and this. I clearly know what happened. I have documented about what happened and everything. So that makes it a nice case in my eyes. Okay.
Mariano, would you remind me how to tell left from right by the diaphragm and the esophagus? I've forgotten.
Yeah. So it's not the esophagus, is the Colvina cava. So the rule goes like this.
Oh, yeah, sorry, the caudal. Okay. Yeah.
So the Colvina cava. So there are some things that you need to remember, and then probably the only thing that you need to remember, two things to remember, and then once you remember that, you can, let's say, reconstruct the argument. So one thing to remember is that the Colvina cava goes into the right part of the diaphragm. not to the left, to the right. That, I don't know why, for me, that's very easy to remember, but that requires a memory. And then the second element that you need to remember is that when you have a dog laying on the side, let's say right side down, then the right part of the diaphragm is going to be more cranial compared to the left. Makes sense? So the one that is on the dependent side moves cranially. So then having those two elements in mind, then if you look at a radiograph, then you need to identify, then you say, well, what's the diaphragm that is more cranial? And probably, see, this is a little bit a confusing one, but I would say this part of the diaphragm. And then the next question is, can we tell if that's right or left? Make sense? And then we are gonna use the Corvina cava to decide if that is right or left. So if we follow the Corvina cava and it kind of blends, meaning that now once the Corvina cava gets in contact, not in contact, but gets to the point of that diaphragm, if we lose the contours, it means that that's going into that part of the diaphragm. There is no superimposition. So then we conclude that that's the right. So in this case, I can see a Corvina cava coming here, and then I don't see any line here. That would mean that it's superimposed rather than going in. So then I kind of conclude this is the right cruise. And if the right cruise is more cranial, therefore the dog is laying on the right side down. And it should be a right lateral recumbency. This is not the best example to decide that because the diaphragm here is not that clear. But I think if I haven't put notes, then I'll get some notes because I have very nice examples, like examples where these principles are extremely clear. And then you can review them quietly and go through the information. I think once you make that jump and you understand it, then you always remember. It's just one, and probably forcing you to use it, every time you have a case like this, figuring out, first taking both laterals and then trying to figure out without looking at the markers or checking if the markers are right every time, then that becomes a mechanical thing and a very easy thing to go through. So I'm unhappy because this is not the best example, and I wanted to show you probably a left lateral, but okay, let me see. Because we have a thorax, so this is again a right lateral. So in this case, we have, this is a left lateral. Okay, good. So let's take this as a counter example. So now we see the Corvina cava, and in this one, let me use this part. If we see this line is interrupted. Makes sense? So we can continue that line. And if we get this line here up to this point, this line continues. Makes sense? So what it's telling me is that in this case, that part of the diaphragm is not the right. And what it's telling me is that this part of the diaphragm is the right. Makes sense? Because the right part of the diaphragm is that one, where the Corvina cava kind of merges, rather than opposite to merge would be to be superimposed. When it's superimposed, we can still see a line on top, and when it merges, we don't see any line. So in this case, so then Corvina cava, that I cannot see a line. This is tricky because there is a line there. So if I don't see a line here, then makes this right. And if that right is more cranial, it's a right lateral projection. In this one, I follow the Corvina cava, and it seems to be going into this one, not into this one. Therefore, this should be right, this should be left. If the left is more cranial, it's a left lateral recumbency. So I know that other people use how they cross. I don't like that, and I'm not saying that it's wrong. I'm saying it doesn't work for me. So there, I don't even remember that. In one situation, they go parallel. In another one, they cross. In my eyes, there is a lot. With the Corvina cava, there is some variation. With the other one, I think there is even more variation. So I'm not saying you shouldn't use it. I'm saying if you need to clarify that, you need to go to the book, because I don't keep that in mind. I I don't remember exactly how it goes. For me, this one is a very easy way to go because I always remember, like anatomically, the columnar cava is in the right. That's easy for me to remember. And then once I get that, then everything else falls in place. It's very natural. Okay. Okay. Any comments? We've had like many cases with obstruction. I remember we got like a run of, I don't know, like 5 cases where I show you foreign bodies. I think we went through interoception and gravel sign. So we've been through that a lot. And it's a very clinically, it's a key. I mean, this question we have all the time, like vomiting, young vomiting dog, is this surgical or not? So I think we need to be sharp in this.
I will start. I think I think there's good serosal detail.
Mm-hmm.
I don't think there's free fluid or free gas. I think that there's probably an abnormally large amount of gas in the bowel generally, not the stomach, just the bowel. And I think it's the small bowel. Most of what we're seeing is small bowel gas. I'm interested in I feel like it's unusual to have the small bowel so far cranial and up here as well. But I don't know if that's correct, but it seems a little bit too far cranial to me. And I think it's small bowel because I think what you can see, I think you can see like ingesta in this sort of mottled appearance that I think must be the descending and some of the transverse colon, although I can't see it on the DV. So I think that the large intestine has ingesta in it, or feces, and I think that's what we're seeing is generally small bowel. I think this extra like large piece of gas, which is generally, it's just on one view that it is so large cranially. I think that's abnormal, but it wasn't repeated. So it's not necessarily, I don't know if you can count that because it would be, I think the width there would be abnormally wide, but given it's not repeated, I don't know if that is, means that it is a problem of distension. There's a lot of bunching of intestines quarterly, but I don't know if that is, I guess that doesn't look pathognomonic for anything to me. And I'm concerned by this large pocket of gas, which is only on a couple of views. It's not on all of them, but I'm wondering if that is large intestine because it does seem to border with some ingesta up there. I'm not sure what that is, but I guess I'm thinking it's large intestine. Yeah, I think that's done.
Awesome, excellent. Okay. So I suppose now it's time for, okay, keep on bringing stuff. Other people, they may have seen something different. If that is the case, just bring it on. And then if it's not the case, for example, disagree with that or agree but you want to add to that, then this is the time to either, so it's like we kind of build something now, and now it's time to either put more stuff on or say, I don't like that building. And the reason why I don't like that building is because I disagree with this. Make sense? So now we can go through that. I'm staying away from saying if I agree with you or not. I think what you wanted to communicate was very clearly communicated. So it's very good.
I agree with Bron, but the other thing I noticed is there's little pockets of gas there in an area that's lost some serosal detail, and I'm not sure, but I'm wondering whether that's free gas or gas in the wall of the intestine. Also, the other thing that I notice is there's a round body there. I'm just trying to draw around it, but it won't let me. There's a round object here that's well circumscribed.
Oh, okay, I see. So it's kind of, let me see if I can help you. Something like this?
That's it, yes.
Okay. So you are basically, to summarize, you agree you are adding the possibility of having gas within the wall of the small bowel, and then you are saying, well, is there a foreign body? Is there something there? Maybe if you want to stay very much away, then we can say, is that a mass effect? That's the most least committed way to say it. There's a mass effect. The other one will be, is that a mass? No, it's not an effect. Now there is a mass. And then I suppose someone could argue, is that also superimposition of something, not really an object, but just the creation of an object by the superimposition of different structures at different levels. So those are options that you haven't considered them, but I'm just putting them out. So, but these are the two things. So the possibility of a mass effect, and then the possibility of free or gas within the bowel wall. Okay.
Yeah, or even free in the abdomen, just in that area.
Okay. Good. Be aware that I say good, and I'm not saying that I agree or disagree. I'm just letting you go, and then you agree or disagree with yourselves, and then as usually I'm gonna give my input.
Also, there's a fair bit of there's enough fat in the abdomen to give, as Bron said, reasonably good contrast, serosal detail. So it's an acute onset, not a chronic one.
I'm going to disagree with myself. I don't think that this can be the large intestine, because I think it's in the wrong place. I think it could be on the VD, but not on the lateral. So I think it must be in the small bowel.
That's exactly what I was going to say. I was looking at it on the VD, the square thing. You can kind of think that it's in the large intestine, but it looks too far ventrally to be large intestine on the lateral.
Okay. So then there is a question mark about that lucency. Yeah. A question mark in terms, is that in the or is that in the small bowel?
Yeah. I agree with Bron. Like, I think it generally there's more gas than you would say is normal, but it's not sort of overtly obstructive at the moment. But that square area is definitely, like, if it is small intestine, then that would be abnormal, like obstructive, but you can't say for definite.
Well, that large gas there has a very straight border on it, which suggests that it's up against something flat. I think the other thing that interests me is the way the intestines are looped around it. So there's a certain mass effect there as well.
I see what you mean. And I will probably add, because I think this is an interesting point to explore, that sharp border is not only sharp, but kind of very straight, like here. It's also present here. And then, so one consideration that you are, one of the things that you are considering, which I agree, is that based on the opacity, that could be gas. And if it's gas, then in order to have that very straight border, it has to be against something that is very sharp. So could it be that now we are dealing with whatever we don't see is a foreign body, for example, that has that border, and then there is gas against it. So that's probably one consideration. I would add to that consideration, it's a very unusual consideration because it's usually what we have is fluid against an obstruction. This would be, it's a very unusual, but I'm not saying that that's wrong. I'm saying I'm not, it's a good idea, but it would be a very unusual situation. Make sense? So having a foreign body, that's not unusual. Having a sharp border, that's not unusual. What would be unusual is that in two radiographs, we have just gas against it. And that the shape of that gas against it, the shape, the amount, the diameter is very similar in two projections. Make sense? So to have that situation where we have gas against a flat border of a foreign body in two projections, I think it's a good idea. I think it would be very unusual to have it in two projections. But that, yeah, just a little comment. I like the way you are thinking. And then
could it be a like that's the actual foreign body, but it's gas filled?
Okay, so that perfect. That's another consideration. And then that we can make it work a lot easier. Makes sense? Because, well, so if we have that consideration, if we have that as a hypothesis, then what is easier to defend or to explain is that that's now is no gas, now it's a structure, and therefore we can explain why it has a similar size shape in both projections, because now it's not gas that is moving around, but it's an object. Yeah, so that could explain that. The part that is in this hypothesis, the part that is unusual would be the opacity. Makes sense? We don't have that many foreign bodies. It's a very unusual thing to have a foreign body. Your comment was, can it be gas filled? Can it be something that contains gas? And I suppose yes. What I would argue in that situation is that I don't see any wall. And then the other one is, can we have something that is like a radiolucent foreign body, something that is less opaque compared to fluid? So that's the other consideration. And it's unusual, but that's an option. Okay, anything else or another hypothesis, any more ideas, any more findings?
I was wondering if that the soft tissue opacity that Jeff pointed out in the craniodorsal abdomen was just like an area of loss of serosal detail. I guess it's kind of in the pancreas region, like a.
Okay.
Whether it was more, yeah.
Okay, I take note, and then I have an observation about that. Probably I'll make it now. So if you, let's say, magnify and window, I don't know, you try to look very close in there, the opacity is kind of slightly heterogeneous, and there's some little bits of gas. And based on position, I really like the first hypothesis, which was this is just a colon and that's feces. I think, again, I would argue that this is the same, and the one is ascending, there is a bit of transverse, and then there is descending. So, and why I'm thinking like that, probably the opacity is giving me that certainty, that mixed opacity, which is characteristic of feces. And then if I come here in the other projection, can I see the same thing? Well, I do. Then I can even continue down there. So I think there is a mix of kind of a granular appearance with mixed gas and soft tissue opacity. And I think I can continue it like this, and then it comes down here. So probably this is secum, ascending, transverse, descending. So then I can see it in two projections, and it will be, so if you connect these two things and then you make it go down there, then I think and then you can make it down there. The possibility of that being a mass with almost like a minimal mass effect, then it's hard to defend. And then even if you go that way, then the question will be, where is the colon? So makes sense. So I think if you explore that, I see that it calls your attention, but I think there's enough argument or information there to kind of conclude that that's very likely the colon, ascending, transverse, and descending colon. In terms of the everyone mentioned about the loss of social detail, and I share with you that even if you come to this projection, it's hard to see the contours compared to here. My advice is to try to stay away from reading serosal detail in the center of the mess, you know, because there are many factors happening there. It's not only there's so much superimposition. It's the thickest part of the animal. So if your only argument, if your only finding for loss of serosal detail is going to be based on your something that you picked in the middle of the abdomen, make a huge question mark. If you find some loss of serosal detail in the periphery where there is, why I'm saying periphery, because there is less superimposition. It's a thinner part of the dog, and then you don't have too many structures superimposed. Then that makes the call stronger. Makes sense. So if you see there, then you can add something that you see in the middle of the abdomen. If the only argument is going to be loss of serosal detail in the middle of the abdomen, make a big question mark, because it's very likely they are being not confused, but you know, is what you are actually seeing is not so much loss of serosal detail, is you are seeing through so many structures that then it's kind of a noisy part and very. It's like the grapes. Don't go in the center. Try to see a grape. It's easier to see a grape, and if there is contour or not in the periphery where there are less grapes. That kind of is the idea. Okay, so any more findings? I want to continue.
And notice also there's an increase in soft tissue opacity just beyond the, and that's visible in this as well.
Yeah.
And it's around there. And you.
Yeah.
Oh, that there looks as though it might be a wall.
The left is playing difficult because in the left it's very hard to see that. I suppose there's still something looking like square, but it's harder to see on the left. It's very clear on the right and very clear in the video. And I agree with you. I would probably argue that, I know it's hard to make the connection, but one of the things that we are considering, because it's a vomiting dog, is a foreign body. And then the comment was, well, based on the position, not here in the VD, but in the right lateral projection, is probably not in small bowel. So our immediate next reaction should be, do we see any evidence of mechanical obstruction? Do we see anything consistent with dilation of the small bowel? We went through that and it wasn't very clear, but coming back, I think someone mentioned the distension. This is a soft tissue tubular structure with a little bit of gas. So even though I can't connect so if you measure the diameter there, that's objectively abnormal. So if we can convince ourselves that that's small bowel, even if we don't see connected with that, then we have two elements. We have the element of a potential foreign body, and then we have the element of a mechanical obstruction. And I'm saying mechanical because this is one segment of the small bowel, and the rest of the segments of the rest of the small bowel looks kind of normal in diameter. So you haven't put all of that together, but I think it could be someone could bring all of these findings together and at least have a hypothesis about a radiolucent foreign body and then a focal distended bowel loop that is not consistent. It's only in one projection, so that is bothering, but it's there. And then at least say, well, I can't rule out a foreign body. It may be a mechanical obstruction.
Mariano, I thought that was the spleen here. Like,
Okay.
is that really wrong there?
Yeah. So why? I think you can't think that, and I'm gonna try to prove you wrong. I'm not sure I have a lot of arguments, but one argument would be, usually the spleen is not, it doesn't continue like this. Makes sense? So it's gonna be more like this border. So I see what you mean. But then I think it's a bit more tubular. And I think what is convincing me that that is not spleen, but intestine, then we can discuss if that's colon or not, or small bowel or not, is that in association, in contact next to that structure, there is this distended.
Yeah.
So then I want to put this together with that. And I probably don't want to think that this is pylorus.
Yeah.
Because the pylorus should be somewhere here. It's thin, this is difficult, but I think it's easier to justify putting this gas together with this soft tissue loop or tubular soft tissue structure. Again, tough, because if you give me the same image here or something easy to see here or on the other projection, then I would be more confident. I understand your reluctance to be confident because it's only one projection, and I understand that. Yeah.
The without
I'm not saying that this is the way to go. It's just one hypothesis. Sorry.
Yeah. Without even this distended gas that we were talking about quarterly with that sharp straight border, I think there's enough gas everywhere else, a sufficient diameter to say that it's obstructed. Because my understanding is that if you've got greater than 1.6 times the width of L5 vertebral body, it's a problem. Mm-hmm. And subjectively, without measuring it, it looks like in a few places there are, and in a few places it's like 2 times the width of the vertebral body. But I'm only looking at gas, even if we include. So can we do that? If that rule is correct, can we also do that where we're seeing tubular structures, or is it safer to just do that with gas?
Okay. So gas or I would say, I will make a clear-cut statement. The amount of, and it may not be like that in real life. I think it's a very useful thing, a way to think about it. I will not pay attention to the content. So if it looks too much gas or too much fluid, I will probably not take that as a first feature to go anywhere, to make any conclusion. It's about the diameter. So that you see too much gas, I will probably ignore. There are some exceptions, but in this particular case, for example, the amount of fluid and gas, I don't think is unusual. And then here I would say probably there is a bit more gas than usual, but I don't think I can conclude anything out of that. The strong feature out of the small intestine, the one that we should be more concerned and more in a vomiting dog, is the diameter. Okay, so, and I like your rule. So it's 1.6 times the height of L5. So it's L765. So if we measure that, so that's 1.2. So then we need to go 1.8, 1.9, something like this. So if we go here, we are borderline. I think this is probably colon, probably secum, so I don't want to measure that. If we take this as small bowel, we are obviously above, we have 4. If we take that, that's not abnormal, I'm sure, no. So if we use the same rule and we come here, again, this one is gonna be borderline, likely 1.6, probably not affected. This one is gonna be normal. So it's not overwhelmingly, unless you take this one, and then then that one is clear. If you can convince yourself that small bowel, then it's unquestionably distended. And then forget about the content. It can be distended gas field or distended fluid field. It's the same thing. Now we are not talking about the content. We are talking about the diameter. Okay, was that a good answer?
Yeah, thanks. Yeah.
Cool. So maybe we move a little bit on. We discuss, and I probably can give you my assessment. So I looked at, this is a real case, a real life case. So I remember it came, and I think I went as far as you done, and then I was concerned about these two things. So I was concerned about this one, and I thought this is very likely small intestine. So my decision was, I wasn't certain enough to say go to surgery, but I thought this together with this, and I was really bothered by that very flat line. That's a very unusual thing. If we believe this is gas, it's very unusual for gas to go against such a long, well-defined flat structure. Feces don't operate like this, makes sense. So if there are feces in the colon, they never are flat like that and then just go like this. So that's a very unusual image. And then I considered the possibility of a radiolucent foreign body, but I wasn't sure. I said, I'm bothered by that image, and I can see one distended bowel loop. So for me, it wasn't a difficult, for sure it was in my eyes, or when I had this case in my hands, probably someone else could have, but in my eyes, it wasn't enough information, or I wasn't convinced enough to send this dog to surgery. So I decided to go through ultrasound, because an ultrasound can help me. Is this really a foreign body or not? It's a very unusual thing to have radiolucent foreign bodies, but that flat line was warning me that something very unusual is happening, that is very likely not gas, or there is something weird going on. And then that bowel loop down there that is not consistent, but it's in a vomiting dog, young dog. So then I can't ignore it. So then we decided to go through ultrasound, and I'll show you. But again, this is a very difficult case. That's why I'm sharing, and you will see there is a very cool thing. So I went through the whole ultrasound. Well, one more thing to comment on that we kind of ignore is that usually when there is an obstruction, one telltale, one structure that can help us make that call is the stomach. So usually when there is an obstruction, even if it's high or even more low in the GI, just because there's an obstruction, there's an accumulation of fluid and gas in the stomach. That's not 100% because the dog could be vomiting. And then the other possibility, not to have overwhelming evidence of obstruction, not only in the stomach, but in the small bowel, even though there is a foreign body, is that one is that the animal is vomiting and is releasing all of that fluid that otherwise would distend the GI tract. The other option is that we have a partially obstructed foreign body or a partially obstructed lesion. And then that is allowing some of the content to go through, some of the content stays, and therefore we have, let's say, weak features of obstruction. And remember that our call about obstruction is usually indirect. We very rarely see the primary, we see the consequence. So either if it's very high, or if it's vomiting a lot, or if it's partial, now we are dealing with a difficult case because it's not giving us the elements to work, which is the distension. Make sense? So this is a case where in my eyes, I thought, well, it could be one of those, this is not helping, that the stomach is not distended. So that goes against the idea of an obstruction. And then in the ultrasound, when I remember I started, so, in order liver, kidney, adrenal, the stomach wasn't very distended. And I said, well, I don't know. I was really concerned. In this case, I was a bit lost. And there were elements on one side and elements on the other side. And I forgot to answer the pancreas thing. The pancreas thing, I think is a good idea. The reason why I would not think this is likely to be pancreas or pancreatitis, even though pancreatitis could result in a mass effect, or most of the time does, with loss of social detail, is that it usually sits anatomically in between the stomach and the colon. So I would expect the mass effect originating here rather than here. Make sense? So it should be more in the cranial abdomen, and then in the DV, it should be sitting here. So it's a weak thing, but I don't see the mass effect, or if that is a mass effect, I don't see it originating where it should. I would expect it to be more here and not have bowel in this area. And the bowel being displaced caudally, not originating from here and then the bowel all around. Okay, so that's my comment about the pancreas. So spleen was okay, kidney, left, adrenals. There was a bit of fluid, and that was a bit concerning. Then I said, well, even more confusing evidence. You know, some things are telling me it's not an obstruction. Some things are telling me it is an obstruction. Lymph nodes have been abnormal, heterogeneous. Was a young dog, so not that. But ileocolic was okay. The ileum wasn't distended, so I said, well, that could. Well, not a lot of information there. And then, almost at the end, I was about to give up. I found this. So this is a hyperechoic structure with shadow. I follow it to one side, and I could see that it was connecting with something looking like small bowel, like here. So this is a normal small bowel. And then something very sharp, again, abruptly sharp, similar to what we saw in the radiographs, was there. Again, the same thing, trying to document that is within the bowel. Makes sense? This is a normal looking bowel. This is something within. I remember it was very hard to see any distended bowel. You could see this appearance on one side and the same appearance on the other side. And if you do a cross section, it wasn't like a big, like a rounded foreign body. It was something like more flat. So after all of this, I'm putting the knowledge from the radiograph together. The hypothesis at that time was, well, certainly there is a foreign body. It's certainly within the bowel. So now, even with that only, I would probably send the dog to surgery. The hypothesis was, well, it's flat, and therefore there is a partial obstruction. And maybe that is that. So then, with all of that, time and effort and everything, I think we decided to go to surgery. But I remember I called the surgeon and I said, look, I think I have enough information to go ahead. But if you come out of that surgery and you tell me that you couldn't find anything, I will not be extremely surprised. I will be surprised because I think there is more towards this is a foreign body that is partially obstructing. That's why there is not that much of distension of the bowel. And it's very likely it's a really loosened foreign body. So I think I have evidence for that, but it's not an easy case. It's a very difficult case. There is no distension. That is the hallmark and things like that. Okay. And then, so this is to show you one case where there are exceptions to the rule. Then they send me a message saying, you were right. And this is the object. So this is like a rubber, but that very light rubber with a lot of air inside. And the shape, I don't know if you can see from the image, the shape is kind of like half tube, makes sense? So it's concave here, and then this is kind of a square thing. I don't know where you use this, maybe to cover a tubing or something like that. And basically, there wasn't any evidence of obstruction. And somewhere I got the image of the bowel, which was normal, this, and normal. And that was intraop. I forgot to bring it today. I can put it on there. So basically, this is a difficult case because the shape of that object wasn't completely obstructing. So then the evidence of obstruction was very weak. Content, I can see content, probably fluid content going through, this creating kind of a little cavity, and fluid and gas probably being able to go through. So wow. Difficult case because of two things: the opacity of the foreign body, very unusual, and second, the shape of the foreign body, resulting in a partial obstruction rather than a complete obstruction. So this was to bring an exception to the rules. You know, we know all the rules, but we also know the limitations of the rules. And then this is a clear case of, you know, an exception to the rules, an exception to the 90% of the cases that we deal with. And I wanted to be sure what we were looking at. So I decided to take this bag and take a radiograph. And then this is how it looks. So if you take this bag, I mean, actually, this bag, this is what's on the X-ray machine, makes sense? This is the laser to position this. This is a plastic bag. And then I took a radiograph of that. And this is how it looks. Is there anything bothering you from this radiograph?
It's fairly opaque.
Yes, I completely agree. So it's opaque. How can you reconcile both things? Why so radiolucent here? Why so radio opaque in here? It's the same object.
Because the radio opacity is the same as the soft tissue and fluid in the dog, so it kind of disappears.
Okay, can elaborate a bit more.
So like on the table, you've got nothing around it. You've just got
Okay.
air, so you've got contrast. Whereas in the dog, you've got the soft tissue and the fluid, and all you can
Good.
see is the air down the middle.
Good.
With
So
the-
then I thought that is the case.
Mm.
So I decided to put fluid in that bag.
Mm.
And if you put fluid in that bag,
Okay.
now it becomes radiolucent.
Hmm.
And then, so this is a mixture of, your eyes are tricking you because it's very likely that the opacity here and here is the same. But because the background is different, your brain is telling you that this is darker compared to that. Make sense?
Yeah.
Your brain is telling you this is white, this is black. It's very likely that if you measure the opacity of this, optical opacity, this is the same as that. Your brain is tricking you because this is surrounded by black, this is surrounded by white. And then along those lines, I wanted to show you, I should have had this ready. Hold on one second. Because I was looking in a book, I remember loving this when I was reading, studying. Okay. This is explained in this graph. So this square,
Mm.
same color, but it has a different, let's say, boundary. Makes sense? So this is surrounded by a more white, and then you see that as darker compared to this. Makes sense? If someone makes you ask you, is this more white, darker or not compared to this one, it seems to be very obvious to say, well, it's darker here. Well, actually, it's the same, but your perception of that changes depending on the surroundings. And I think this is exactly the same what that is happening here.
Mm.
Okay, so this is the same object, and I give faith, I did it. So it's exactly the same object. I just put fluid around, and in one looks like a bone, in the other one looks very opaque. The surroundings really changes how you see. So I love this case because first it's an exception to the rule, and it's always good to go through exceptions because that should give us and makes us humble when we use the rules. Makes sense? Because it's not that we have our rules are all 100%. They are not 100%. So an obstructed dog usually has a distended bowel. Well, not all the time. That depends in if it's vomiting or not, a lot, and it depends if it's a complete or partial obstruction. So this is a very beautiful example of a partial obstruction. And then the other thing is that most foreign bodies are radio opaque, but not always. Sometimes they are radiolucent, and like this in this case. And then on top of that, this brings also more breaking rules in terms of attenuation. So if you look in a radiograph, we know that the attenuation, the colors, depends on two things. Basically, one is the composition, soft tissue, bone, fat, air. That we know. The other one is the thickness. If you have something that is one opacity but is thicker compared to something else that is different opacity, what we see changes. So thickness is one, composition is another one. And then on top of that, we have our brain that tricks us. Make sense? In seeing one thing or the other depending on the surroundings. So for me, this is an extremely humbling case where if you are too hard on the rules and you are too, I don't know, you trust too much on your rules and you cannot consider that we may be dealing with exceptions to a rule, we may have failed. This needed some flexibility and being humble, even though the findings are not 100%, still pursuing the case because there was something that wasn't fitting. And then also this, which I find beautiful, is like this kind of optical illusion, which is beautiful.
Random question. You said you found the foreign body and there wasn't overt signs of obstruction either side of it because it was a partial. Is there a way you can differentiate that between a partial obstruction and a foreign body that's moving through? Like, would it have been reasonable to give a bit of time and re-x-ray and see if it was moving? Because, you know, sometimes we're kind of following a foreign body going through, I guess. Is there a way you can differentiate that? Or is, I guess, an option sounds like a snapshot in time, isn't it?
So I don't know how the moving thing goes. So if it's moving, I think it's more likely to be partially obstructing, and therefore it can operate more like this. On the opposite side of that, if it's really stuck, then it's likely to be fully obstructing, and therefore then bringing more distension of the bowel. I can see exceptions to the rule again. Makes sense? So I can have a foreign body that is kind of sharp and is going through the wall and is really stuck in there, but it's not fully obstructing. So I think adding the thing about moving or not moving, I think it doesn't help. Makes sense, and it's very hard to know if it's moving or moving. I think regardless of the motion, I think the key element here is if it's completely obstructing or not completely obstructing. And I think that part is a very good consideration to keep in mind. And again, try not to be, in this case, I mean, if you have a case where there's a lot of distension and you see a foreign body, then you don't need to hesitate. You need to hesitate in cases where radiographs are not very rewarding. I'm saying in that situation, you can never completely rule it out. Make sense? Because then there may be the exception to the rule operates in that end of the curve. Makes sense? Is where there's a partial, there's something perforating, and then we are missing the important part, which is the distension.
Yeah, I guess from a clinical point of view, I'm thinking, would it have been reasonable to give that dog a bit of time to see if the foreign body had moved, or was there a definite reason to take it to surgery right that second? Do you know what I mean? Like, just in terms of decision making, like if it's only a partial obstruction and it's not overtly obstructed either side, is there something that you saw that said like this dog needs to go to surgery now versus we can give it a bit of time to see if it moves on its own, if you know what I mean?
So I really like following up studies. I think they hear a lot of noise. So I'm all about that. And if we come back, so I think that's an extremely valuable tool, extremely, and removing the anxiety from the case and taking another radiograph and making sure that the dog is not fed in between. I mean, that's excellent. I love doing that. I think brings a lot more information and is excellent. Now, if we need to answer your question, probably based on radiographs, I think one possibility and a certain possibility could have been waiting, no problem. Then the minute that I did the ultrasound was the minute that I knew that there was a foreign body. Makes sense? So then there wasn't any more questions about the foreign body. And then the other element that I don't think is clear cut, but I think is a very supportive element to push to go in, it was that there was a bit of fluid.
Yeah, that makes sense.
Those two elements, I think. And now we've always spent the money, makes sense? So now how I'm gonna follow this up? I'm gonna do another ultrasound. I'm gonna find the same thing again. So then, yeah, I think we got to the end of what we can learn without opening. And then I think we have enough now.
Yeah.
If you remove the ultrasound, and if you put yourself back into, we have these radiographs and we don't know what's happening, I would certainly welcome taking another set of radiographs. I'm not sure in this particular case if that would have helped. Probably, I can say if you take another set of radiographs in 6 hours and you still see that sharp gas delineation, even if you don't know, you need to say this cannot be gas. Gas is never the same after 6 hours. So that I can see that probably that could have given you more decision, a stronger argument to go forward. Yeah. So to answer to your question, I think situations like this, where you take a first set of radiographs, things are unconclusive. If you don't see free gas, free fluid, and you don't have ultrasound, fasting and repeating is lovely. I think in many cases, you just clarify and remove noise, and you can make a call in the second radiograph. Yeah. So I love the tool. This is a little bit of a luxury situation where I was around, and they said, well, the owner is willing to do the ultrasound. And I said, well, I don't think I don't think it's wrong, because we had these 2 question marks. So I think it's indicating in this case to go further. So then we decided to go this way. But without that situation, either the owner doesn't have the money, or there is no one around to do an ultrasound, waiting and then taking another radiograph. Perfect.
How long do people normally wait?
Well, I suppose that depends a lot upon the
Clinical condition?
clinical condition, yeah.
We normally do about every 6 hours, 4 to 6 hours.
Right.
Yeah.
Another thing that I probably is worth mentioning here, in this context of trying to decide what's the workflow, what do we do next? If you're in that situation where you have radiographs, you don't have an ultrasound, or I would say probably it's not because I did it, but I would rate this ultrasound as extremely difficult ultrasound. It was very, very hard. I was about to give up, and then I said, no, there's something wrong in that bowel. I need to keep on looking, and then I found it. But I don't think this is an easy case. So in that situation, and in the context of a foreign body or a vomiting or a confusing radiograph, the other thing that I would do is do a pneumocolon. So usually the problem is this colon, is this no colon, is this distended, not distended? And usually what gets in our way is deciding with certainty, this is small bowel or this is not small bowel. So if you're in this situation, fast the dog, because the other confusing thing is content in the stomach. Is the content in the stomach a foreign body or not? So fast the dog, make sure that it doesn't get any fluid, yes, but no food. And then you take it first without pneumocolon, but we are ready to do a pneumocolon. And you take another radiograph 6 hours with pneumocolon. If you do that sequence, then I think that is super helpful. And if you have someone with experience looking at both, I think you can solve most of the cases.
Mario, it just interests me that the clinician didn't pick that up by abdominal palpation, because it looks as though it should have been palpable. And
so it was, let me bring this back. There was a comment. There was an uncomfortable abdomen. So here, I forgot to show you this. Some feces, vomiting after dinner several times, not eating today, not drinking, no diarrhea, hard mass felt in the caudal abdomen.
I can remember surgeons in America going in on a case, it was a corn cob, just on the basis of palpation.
Yeah. And then, exploring. I'm all about that. Hey, no problem. So we are trying to learn more, and sometimes the information is there. So that's what we try to do. Like a radiograph, 2 radiographs is if you can know where to go, or if you can prevent going in without necessity, without the need to go in, that why not? But yeah, there is a point where you may need to go in to explore. Yeah.
Mariano, the difficulty you had with the ultrasound reminds me of an adage I adopted carving cows, is that success follows the period of maximum frustration.
Yeah, but it's also a humbling thing. It's a humbling thing. I remember thinking when I finished this, and when they sent me the photo I said, well, this wasn't an easy case. It was like a really stressful case. There were like things here and there. I couldn't convince myself about it, but at the end of the day, I decided to send it to surgery. Yeah, it was difficult, and I could see that I was almost giving up on the ultrasound, almost giving up, and then something brought me back and said, thinking about the whole case, it's a young dog. That gas, that loosened structure in the abdomen is not normal. So let's keep going. And I said, well, hold on, I need to do it. I want to keep on going. And I stayed there longer, and then I found it. But there was no distension. So usually the way that you deal with a foreign body or a mechanical obstruction in ultrasound is you find the distended bowel loops, you trace it one way and the other, and then you get to the point where the problem is. In this one was no distension at all, nothing. So it was extremely difficult to find it, yeah. Okay, done. Interesting case. When I got this photo and this object, I said, oh, this is a beautiful case for rounds, because it's very unusual to have a radiolucent foreign body. It's very, very unusual. And then this optical illusion, which is also cool. I remember reading about it and loving it. Yeah.
Great. Thanks for sharing.
Yeah, that was really brilliant, Mariano. Thank you.
All good. So
Thank
we'll see
you.
you in 2
Thanks,
weeks.
Mariano.